morning to everyone. I want to thank the organizers for inviting me to speak at this session. I am honored to share the podium with such a distinguished panel. At first, I was hesitant to approach this topic without knowing what the previous speakers were going to say, but I believe that the title that the organizers chose for this topic, ending in a question mark, provided a clue that I should draw on my experience as a reviewer of the many pediatric APS manuscripts for a number of journals. We would all agree as pediatricians that children are different than adults, and also that they are not just small adults in reference to size, weight, and body surface area. Since I am going to be giving a toast at my son's wedding this coming week, I am reminded of the movie My Big Fat Greek Wedding, in which the father of the bride gave a toast and discussed the Miller family. He said that Miller comes from the Greek word milo, which means apple, and that the Portokalis family comes from the word portokali, which means orange in Greek. That even though apples and oranges were different, they were all still fruit. We know that there are further differences, perhaps not so drastic a comparison as apples and oranges, but more of a continuum within the same family. So, maybe we are all citrus: limes, lemons, oranges, and grapefruits. And not only are we different on the outside, but also on the inside. Patty Massacott and I have spoken and written about these differences in the past, a topic called developmental hemostasis, differences in the coagulation and fibrinolytic system. In the ages between 1 year and puberty, the levels of some of the components of the coagulation and fibrinolytic systems are significantly different than in adults, and in some cases the levels are similar to those found in patients who are maintained on warfarin. This is combined with the relatively healthy vascular endothelium and perhaps less of the independent risk factors found in adults, some of which may become more relevant in the post-pubertal years, such as smoking and birth control pills. Hypercoagulability, stasis, and vascular injury. All these must be taken into account in a delicately balanced system in order to assess relative risk for thrombosis. And because of developmental hemostasis, risk is a moving target. So, what else do we need to consider? We know that genetics plays an important role in autoimmune diseases, especially in SLE. We know that race and ethnicity are therefore important in examining the manifestations of a disease process. This has been shown in the Lumina cohort as well as others. Yet, there is a large problem of underreporting in the literature. In the last few months, a number of papers have addressed this in various medical disciplines. This study in particular found that although reporting has improved over the past decade, the problem persists, and this is true of many of the pediatric APS reports as well. So, when we look at cohorts, case series, case reports, and clinical trials, we often see this. All the children are grouped together with little or no attempt to separate them into subgroups that would help define risk and clinical course. Even with some definitions provided in the manuscripts, we see this at best, when we would really like to see this. So how do we get there? We need numbers. It would be nice if our patients were inbred mice. A study with 20 mice could be broken into a control group and 3 treatment arms, and perhaps generate statistically significant data. Unfortunately, the numbers in our cohorts and case series look like this. Obviously, this is not a complete list, but it is meant to be representative. My apologies if your study is not represented here. If we try to divide these cohorts into all the separate groups that we have been discussing, there is no possibility to perform a reliable statistical analysis, even if it were possible to combine them, and we will address that in a few minutes. I am once again reminded of a scene from another movie, and I promise this is the last one. In the movie Crocodile Dundee, the gang tried to rob Mick Dundee on the streets of New York City and one of them wields a pocket knife. Dundee then pulls out a short sword and exclaims, "That isn't a knife, this is a knife." Obviously, we cannot come up with a cohort of 32,459 participants. So what can we do? Many of the reports in the previous slide required a retrospective review over decades in order to get to the small numbers that they actually reported. If there was a way to combine all the reports in the literature and utilize all the data from those reports, and if they actually contained equivalent amounts and quantity of data, then meta-analyses are possible. Ever since I heard Dr. Butte speak at the ACR meeting in 2015, I have been speaking to this group and others about using big data to help us with pediatric APS. I have communicated with Dr. Butte on this subject, and he has shared his slide sets with me. One thing, however, that he emphasizes over and over is the concept of garbage in, garbage out. I don't think we have to refer to our own reports in such drastic terms, but perhaps we can focus on inclusive versus selective reporting in our future manuscripts. Pre-selection of what is important and relevant may introduce bias. This means to include all information as possible about patients in the cohorts, and not be selective and only include what is known to be important today. We have to think about what may be relevant years in the future. This is one way to get from this to this. Many reports in the literature, including those mentioned in previous slides, do contain much of the following, but many more do not. What else is necessary for us to achieve statistically analyzable data through meta-analyses? All the reports do address gender and most age, but only in terms of means and standard deviations. Some do provide age ranges, for example, less than 14 or greater than 14, but very few specify whether the patients are pre- and post-pubertal. Some papers delineate race and ethnicity, but many assume that since the cohort is from a single center in a single country, that this information will be obvious to the person reading the paper. Socioeconomic status, access to healthcare, level of education are all very important in terms of capture of patients into a cohort, ability to follow patients, ability of the patients to understand the importance of medication, and compliance to regimens. Some papers are very good at including this information, but it is lacking in many others. And then there are laboratory issues. Which tests were performed? Specify the specific test name or assay type, even the manufacturer. This is particularly important for lupus anticoagulant assays and APL assays, but it is also not adequate to state low complement. What are the normal values or cutoffs? Were there age-matched controls? Most labs do not provide this, and most authors do not run their own controls. If the study has a control arm, then this helps. This issue is very important for the lupus anticoagulant assays because of developmental hemostasis. Were the assays run on serum or plasma? Were they run on fresh samples or frozen aliquoted samples? Were there any freeze-thaw cycles which may affect the results? Was the test repeated? If not, why not? Were there any interfering substances? If the study includes patients with lupus who may have had alopecia, these patients may be taking biotin supplementation, or they may be taking it anyway. There are hundreds of papers addressing biotin interference with clinical assays that utilize biotin-related reagents. This affects results in different ways depending on whether the assay is a competitive binding or a sandwich assay. Results could be higher or lower than they should be. In SLE patients with endothelial cell activation, factor VIII levels may be elevated. This affects the results of the intrinsic pathway-based assays such as the hexagonal phase lupus anticoagulant, APTT, and KCT. This falsely shortens the screening test, producing a negative result. Elevated IgG levels that are found in some SLE patients or in patients receiving IgG cause ELISA assays to become erratic due to the presence of large amounts of highly charged proteins in the wells. If a test was performed, then include it in the report. and this includes genetic studies that are performed especially on the coagulation system. It is hard to predict what will be important 10 years from now. If any of the information is not available or not known, then state this in the limitations section. Many reports include the following, but many do not. They may seem obvious, but you would be surprised how many manuscripts actually lack this information. For example, what was the rationale for treatment decisions? Were there any unusual circumstances? What were the medication doses per kilogram or per body surface area? What was the length and course of treatment? And were there any issues with compliance? So we are back to inclusive versus selective. Meta-analyses need all the data points available in order to include as many studies as possible. Authors need to include as much of this information as possible, and when that information is not available, they need to state this in the text and/or the limitation sections. Reviewers need to instruct and reinforce the inclusion of this material, and not have the authors remove information that may become important in the years to come. Editors need to act as referees to ensure author and reviewer cooperation. All this may seem obvious, but it is not always. And hopefully in the years to come, we can actually achieve this picture. Thank you for your kind attention and for your patience. I hope you found this talk interesting and provocative. I know that some of these ideas concerning manuscript structure and review processes may seem radical, but I believe they are necessary to achieve analyzable data for pediatric APS. To those of you who are already including this material in your manuscripts, I applaud you. To those who are not, I hope my thoughts will be a helpful guide to you in the future. Once again, I would like to thank you for listening to my swan song to the Black Swan.